Hey everyone. We'll just wait a few minutes for folks to trickle in and then we'll get going. Samara, I'm just gonna give it like 30 more seconds and then we'll go, okay?
Yeah, sounds
I
great.
will start. I'll share my screen. Welcome everybody here. Can all see that? Yeah? Good. Gotta get all my things ready to go to. Okay. So I think we'll get going, folks. Anybody else who's going to join us is going to be considered late and tardy, if that's okay. We allow tardiness here. Hi, I'm Alex. So I'm going to be moderating today's final research seminar, research spotlight webinar. We did a series of 3 this summer, and this is the 3rd of those 3. So welcoming Samara. Sorry, I didn't have a chance to change the slides. Jules is unfortunately unable to make it, but we're graciously have our Samara Mayer or Meyer. Oh my God, I should know this.
Mayor.
Mayer. Okay, I thought so, like John Mayer.
Yes.
Samara Mayer. Um, I'll get into a bit about who you are in a second. I'll welcome everybody to, there is closed captioning on the call, so you can enable that at the bottom of your little Zoom browser there. I am Alex. I'm one of the knowledge mobilization specialists that works for the Canadian Association of People Who Use Drugs, and I work with the National Safer Supply Community of Practice. Oops. Oh, okay, there we go. So we come together in this community of practice across various places across Turtle Island as people who live on treaty lands and ceded and unceded territories. We are all treaty people. Our team is comprised of many individuals and organizations across Turtle Island. I, for example, myself, live on the territories. The custodians are the Ganagahage. This is in so-called Montreal. And I am still learning about the history and trying to work towards figuring out a little bit more about what my place is here in this land. We do work, I'd say, more broadly in a sector whose goal is to address social and structural harms. We recognize the production of these harms does come from a deep colonial history and its continuing and ongoing enduring practices, institutions, and ways of thinking. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are specifically rooted in racism and in colonialism. It is unfortunately with us well today, and we must commit to working in ways that will work to transform racist and colonial institutions and practices and systems, to repair harms, to prevent future harms, and to work towards a more inclusive and equitable future. With that, I would welcome folks. The chat, you should be able to chat with each other, and everybody should be able to see everybody else's comments. You're welcome to provide whatever information you'd like. That could include the location and territory that you're on, the role that you are in, the position that you fill, whatever your name, your pronouns, whatever you'd like to share. A little bit about us. National Safer Supply Community of Practice is funded currently by SUOP, or the Substance Use and Addictions Program. It's a collaboration with the London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, the Alliance for Healthier Communities, and I haven't updated this slide, but it should also say, and the Ontario HIV/AIDS strategy. And it's our goal to support the scale up of safer supply programs through capacity building, knowledge exchange, and skill sharing. We'll pop in the links for our website in a sec, just if you want to learn a little bit more about us. A little bit about today, because I know everybody's wondering, and I'm just going to say it off the bat. We are recording this event. Yes, it will be posted, and it will be available on our website for, I don't know, infinite amount of time. We'll share that after, we'll share that in our newsletter. We'll share that on social media with you so you can access that or share it with other people. If you're having technical difficulties, the best thing to do at this point is to log out and rejoin. Other than that, we can't really do much on our end to help you. And like I did say at the beginning, we do have closed captioning. Unfortunately, it's only available in English at that point, so it's at the bottom of your Zoom screen. We will pop in a link for a certificate of attendance and around the Q&A, or we'll do a Q&A period just after the presentation. At that time, we'll also run like a Zoom poll as well as a feedback survey that you can fill out to help us learn what we did good and what we can do better next time. Also, my colleague Fola will just pop in a link to this upcoming event. It's actually tomorrow at 11:30 Eastern. So if you're joining from the West, it might be an early 8:30 a.m. session for you, but you're more than welcome to join. So Fola's just popped in the link to register for that one as well. And that's specifically on safer supply and nursing. Like I said, learn more, join our community. I'll stop sharing. And what I'll do is I'll turn it over to you, Samara, to then share your slides. I do want to introduce you first. So Samara Mayer's research background is in critical social science research and qualitative and community-based research methods. She has a master's in public health. She is currently completing her PhD in interdisciplinary studies at the University of British Columbia and is a qualitative research coordinator at the BC Centre on Substance Use, or the BCCSU. Her doctoral research focuses on social and structural factors that impact people's experience of injectable opioid agonist treatment, or iOAT, it's also referred to as. Samara is interested in improving health and social systems for people who use drugs. I'm also happy to say that we met each other like 3 years ago through the Canadian Students for Sensible Drug Policy, and it's just been really nice to have an opportunity to reconnect with you. So I'm going to turn it over to you. You take it away, do the things, and I'm going to turn my webcam off for the presentation, but I'll come back when you're ready for the question and answer. Okay?
Okay, I think I'm up and running. Thank you so much for the intro, Alex. So yeah, as Alex mentioned, I'm going to be presenting on women's experiences in injectable opioid agonist treatment programs in Vancouver. And yeah, so I think that was a really lovely land acknowledgement. For my own, I am in the territories of the Coast Salish, Musqueam, and Tsleil-Waututh Nations. Lived here for 12 years, and I'm a cis white woman. And in my acknowledgements and in my research, I try to find ways to align and support with ongoing decolonial work that our Indigenous people are doing where I live. In terms of this research presentation, when I was reflecting on it, I really tried to emphasize the voices of Indigenous participants that shared their experiences with me and provide recommendations that align with changes and perspectives that they valued. So as Alex mentioned, unfortunately, Jules couldn't join me today, but she was a community research assistant on this study. She really helped me a lot with the data analysis and the paper preparations. She has expertise on her neighborhood in the downtown east side where the study was conducted. She has a lot of expertise on women's health issues and drug treatment. And she's also just wanted to plug, she's a prolific writer and she does work with Megaphone magazine in Vancouver. So yeah, check her out. I just also wanted to thank Nancy McDonald. She's a peer health navigator who at some of the iOAT programs, and she helped shape my ideas about the topic and provided feedback on the results. Of course, I want to thank the women who participated in this study and provided feedback on the results as well, and the iOAT staff who supported the study, and just thank you also as well to my co-authors who helped me with data analysis and writing the paper and supporting just the overall study. So this study was funded by an NIH grant, and it's also studied. I had a doctoral fellowship that helped support the research as well. So just to give an overview of where we're going, and so you have a sense of what to expect. So I'm going to go through some background, the study objectives, give a little, I think a lot of folks here are probably really aware what iOAT is, but just a really brief. So we're all talking about the same intervention about what is iOAT. I'm going to go through really briefly my study sites, methods, the findings, and then we're going to talk a little bit about the implications of some of the study findings as well. And this is all just drawn from a research paper that was published in July in the International Journal of Drug Policy. And yeah, so here we are. So for background, women's risk of violence and drug use related harms has been amplified during the overdose crisis. Women are more than 2 times more likely to report unintentional exposure to fentanyl, and the increasing adulteration of the drug supply has heightened women's risk of overdosing and predatory violence, including sexual assault. We know that having an equitable access to different drug treatment options, including in iOAT, holds the potential to help mitigate some of those risks that I mentioned. And we also know that women face a lot of barriers in accessing drug treatment, including stigma, criminalization, violence, economic disparities, and a lack of social support, such as childcare and flexible services. They also risk loss of child custody, trauma, and limited family support in accessing drug treatment services. So a lot of women are underserved and underprioritized in the delivery of gender treatment drug treatment services. There's not as many services that offer integrated childcare, women-specific hours, or trauma and violence-informed services. There has been some past research on iOAT, in terms of women's experiences. And this research has found that the treatment can help improve women's health outcomes, even when women might present with experience of marginalization that might impact their outcomes. And this research has also found some differences in ways that women describe better treatment outcomes. For example, one of the studies I cited here focuses on how better health for women in iOAT meant rebuilding relationships and better self-care. So the objectives of our study and where this study came out of, I think is important also to center is I had some conversations with some of the peer health navigators when I was doing my data collection, and as well as the nursing staff. And they were really interested in the challenges that they faced in retaining and attracting women to these programs. And also we were interested in it from my own positionality as a woman. And yeah, just those ongoing conversations with the peer health navigators who encouraged me to focus on this topic. So as I mentioned, there's some research that has characterized women's engagement and outcome measures with iOAT, but there hasn't been as much on how the social and structural context impacts women's engagement. So that's what this study aimed to do, was to understand how the social context, that is things like gendered norms, income, housing, and then the structural aspects of program delivery, like the program operations, rules, and policies impacted women's treatment engagement. So what's iOAT? I do think, like, I don't know, but I feel like a lot of folks here might know what iOAT is, but in brief, in clinical practice guidance, it's considered this kind of a higher intensity model. And the eligibility criteria for iOAT is you have to have a history of injection drug use with opioids. You have to be diagnosed with severe opioid use disorder. And it's generally, but it's not strict eligibility, that you have to have previous experience with other treatment models like Suboxone or methadone. And IO, you have to come in 2 to 3 times a day. You're assessed by a care provider. Oh, thanks. Very helpful guidelines that Alex put in. So there's a lot of information on how IELTS delivered, but you basically have to come in 2 to 3 times a day, receive your shot under healthcare provider supervision. You have to either inject it yourself intravenously or intramuscularly, or a nurse typically could help you inject it intramuscularly. Um, and some programs have different like policies around how you take your shot. Sometimes you have only 15 minutes to take it. And there's usually a post-dose observation period as well. And some programs have more wraparound health services, like they'll have access to social workers or counseling support. And I'll kind of emphasize that. So in my study there, I recruited folks from 4 different iOAT programs. You can see on the map here in the downtown east side neighborhood of Vancouver. And those 4 different programs included a pharmacy delegated model, and then a comprehensive program, which is dedicated solely to iOAT, and then an integrated model, which means it was an iOAT program integrated with the primary care clinic. And iOAT, my research was done on the downtown east side. Across Canada, there was an environmental scan that was done, and in 2019, there was only 331 people on iOAT programs. And a lot of them were located in Vancouver. And of those 331 people that were on iOAT in 2019, only 32% identified as women and only 1% as transgender or non-binary. Um, as I mentioned, in Vancouver, the highest concentration of iOAT programs are in the downtown east side. At the time of the data collection that I was doing for this study, there was only 2 other programs there's one located just outside the downtown east side and one in Surrey. There's not a lot of these programs. And for my study, we recruited people from these 4 different models. So what methodology did we use? So I took a critical ethnographic approach to the study, and critical ethnography, really briefly, it sets out to critique hegemony. So it's interested in social inequalities, oppression, and asymmetrical power relations, and to foster social change. So when I was talking about aligning with what some of the peer health navigators were telling me to focus on, that aligns with this perspective. It's explicitly ideological, and it's interested in issues of power and inequities. Complementing that method, I focused on theoretical approaches from critical gender and drug studies. And so with that, I'm focused on issues of relationality, that is ways that women engage with drug treatment, relate to it, to people in their lives, embodiment. So that's like ways women describe the way medication feels in the bodies. And lastly, on control, the role that IOT plays in controlling and caring for women and how women perceive this. And focusing on these kind of theoretical perspectives helps frame a way to move away from a tendency in addiction research to pathologize and individualize people, but rather it encourages a focus on these broader socio and structural factors, which were in the project aims. So I spoke to 16 women who did in-depth qualitative interviews with me. I was able to do 5 follow-up interviews. My study was unfortunately, or our study, sorry, was unfortunately quite impacted by COVID. I wasn't able to do the remaining follow-up interviews and planned ethnographic observations. I was able to do 50 hours of ethnographic observations at one of the IO programs, and also one-on-one with participants who were interested in doing that. And then I also, as part of going through the study findings, I tried to do follow-up meetings with people who are women who had participated in the interviews to ensure that the findings were reflective of their experiences and my interpretations were in line with their perspectives and what they thought were important, So these are the demographic characteristics. Just in brief, I wanted to give a sense of who I spoke to and who participated in the interviews. So the mean age was 44 years old. 10 of the women I spoke to identified as Indigenous, 6 white, and all of the women I spoke to experienced some measures of what we social inequities or what's sometimes called structural vulnerabilities. Just means in terms of having insecure housing or insecure income generation activities as well. So as I mentioned before in the methods, our analyses focus on women's on this relationality piece. So one of the relationships women spoke about was with their intimate partners. And so at the time, a subsample of women started iOAT with their partner. And this was done to help recruit more women. And some women, their partners really enjoyed this and they supported each other in treatment. But this could also be complicated because relationships change. And this woman's quote really highlights some of the challenges and complexities in terms of relationships in IO. So she said, my ex-spouse and I have a no contact order now, and we both go to the program and they had to work. So we had to work with management, certain times for me to be able to go twice a day, certain times for him. So there's no running. So we're not having to run into each other. And it was just complicated at first. So I chose to withdraw from the program for a couple weeks. So it just really speaks to kind of the um, challenges with the program and the fact that it was notable that she withdrew and that there weren't any other programs that she could go to at the time. As I mentioned earlier, there's not a lot of these programs, and at the time of data collection, there were significant wait lists for all the iOAT programs as well. So it really negatively impacted her engagement with the program with iOAT. Second, kind of from a relational perspective, an engaging factor for women was the positive relationships they built with care providers in IOT, namely nurses, as they're primarily the ones who are providing this treatment on a day-to-day basis. And this led them to feeling that IOT was a place that was safer than other places they were in contact with, such as on the street, in their building, at overdose prevention sites. And this was made even stronger, these relationships are strengthened when care providers were able to adapt program operations to meet women's needs. And I think this quote's really nice, and she says it really well. And she's talking about how she was with the comprehensive IOT program for a long time. And she notes that rules have been relaxed here, just like observing the surroundings of who they're dealing with, it's just not so medical, so clinical, more like friendlier. It's just more like, hi, how's it going? And, engaged in people's lives, wanting to know, not nosy, but wanting to know and giving a shit about what's going on in people's lives. So this feeling of that care providers could understand, build these relationships with women and then could make slight adaptations to programs to meet women's social context. So maybe perhaps knowing that they were going to be a little bit late for their shot because they had a medical appointment, or were able to just make these little adaptations, and that made women feel cared for in the program and helped with their engagement. But this was often women spoke about this, about being in tension with some program operations. So as I mentioned, you have to go into IO twice a day. Some of the programs didn't have a lot of privacy, and you have to take your medication witnessed way in front of care providers. And that could undermine relationships that women had with care providers, and it made it hard for women to engage with treatment. And it made them feel that the programs didn't understand their social context and needs. And I just wanted to go through an example of how relationship building between women and healthcare providers can be achieved in iOAT, but then and how programs can be responsive to women's social context, but also some of the ways that policies can undermine relationship building and hinder women's engagement. So, and it's around supporting medication administration. So in iOAT, as I mentioned, care providers don't directly IV inject medication, but they can help women inject their medication safely through verbal support. And this gave women more independence and helped them to build relationships with staff. And so this participant on the left here, so before going into IO, she had only been doctored or had someone inject the medication for her. And they had helped her so that she could do it herself. And she just really appreciated this support in the program. And she notes, I can't believe that. That's just like, I really didn't expect them, the nurses, to go so above and beyond. Like they'll teach me how to do that. And I mean, they literally had to sit with me. The nurse said, I think you'd have a more comfortable way of positioning your hands. And she kind of described how the nurse helped her. Um, and the staff went further to help her split up her doses because it went with her schedule better. And they um, kind of told her when it was quieter times at the clinic so she could come when it was quieter. And it was really helped her engage with treatment and build these trusting relationships with care providers. And because healthcare providers knew her better, they understood also like, when she might be late to treatment, she described, or if she needed changes to her doses, and they were able to accommodate her needs quickly. Um, this other quote highlights that interface with the operational aspects that can make it hard for some women. So this participant notes, I didn't like IVing in front of other people, and that was a big thing. And there were discussions of your other medications, and the doctor wants to see you, and you're going down this week. And it was just like, I just didn't want my recovery and its falls and dips to be discussed every day and not in any kind of privacy. So this woman describes how a lack of privacy in the program um, and the requirement to inject in front of others impacted her engagement with treatment as well. So yeah. So some of the last findings are around this kind of um, interface of agency and control that I alluded to in the methods section. So on one hand, IO was really helpful, and other research findings have shown that for women, IO helps women gain more agency. They're able to save more money, have more control over their drug use, and better health. And this woman writes, sorry, not writes, she was telling me about how her relationships changed. She says, I was seeing this guy for a while and I think I liked him because he was a dealer. I could get my stuff for free. So I was, seeking out dealers as boyfriends to keep the costs down. So change would be from like, I had a partner and now I don't. And that is my change. He was a dealer, so I was getting all my jib for free and down too if I wanted it, but he was horrible. He was horrible and treated me so bad. So yeah, I don't miss that and I don't miss him. So she was able to gain more agency and control over her life circumstance through her engagement with the program. But then again, on the flip side, IOAT and the program requirements specifically coming in every day and the inability to receive take-home doses makes it hard for women to live life according to their own terms, such as taking on employment that they wanted, reconnecting with family and children, because you can't take this medication home. And she notes, well, it's hard for me to move forward any further because we're not allowed carries. It's really difficult to it's hard to visit anybody. It's hard to go anywhere. Sometimes it's even hard to get to work on time because I always have to go to the clinic before I can go to work, and I can't go to work sick. That would be pointless and torture. So yeah, I'm kind of just stuck until they get more clinics or more flexible in the dispensing of it or whatever. I'm just stuck with what I have. So just before I get to the key messages and kind of some of the recommendations I think or we thought were stemming from the results, just some limitations to consider from the study is this is really specific to a particular context. As I mentioned, it took place in Vancouver in the downtown east side. We have a specific adulterated drug supply, specific community dynamics. and specific iOAT programs. COVID really impacted the study. I wasn't able to do the remaining follow-up interviews and additional fieldwork. There weren't targeted questions on mothering and motherhood, which is a very important consideration in women's engagement with drug treatment. It came up sometimes in the interviews, and I think it's an area that needs further investigation. And there was limited information on gender diverse people, and there were, because it wasn't represented in my sample, but definitely an area that's in need of further research. So in terms of some of the key messages and recommendations from this study, so just more broadly from a policy and service delivery standpoint, we believe these findings point to the need for gender attentive drug treatment services. And this could include factors both within the iOAT programs that are still operating, but also around the provision of women's a women's specific iOAT program, excuse me, sorry. And so this would help programs be able to better address broader dynamics in care, including intimate partner violence or gender-based violence that impacted women's engagement. And I think it's really important, and what really came out to me when I met with the women for their follow-up meetings, it's really important to recognize that gender attentive services includes diverse service delivery that meets women's needs, various needs, sorry. For some women, this might mean a women's only site, but for others, as I noted, being on iOAT with a partner can be really helpful. So having diverse and flexible options is important. Secondly, relationship building between care providers is really important because when you get to know someone, you can adapt services to meet their needs and make people feel cared for, and you can adapt services to meet their people's social context, which is what women reported wanting from this treatment. Yeah, so, and just to conclude, there's this need to, and what women really expressed was this need to focus on how to encourage women's agency in treatment. And this includes providing flexible treatment models, take-home doses, and that would provide women the independence to work and reconnect with family and children, which is what they want. So just to sum up, relational care in iOAT is important in engaging women in care. This includes adapting programs to meet women's needs and understanding women's social context. But these programs need more support so that they have the capacity to continue to build relationships with women and provide low threshold care that can adapt to women's social context. Just have some of the references here that were cited, and thank you so much for your time.
Thank you so much, Samara. For anybody who's wondering, we do have a permission to put the recording and the slides of the presentation up on the website. So please do stay tuned for the link. Thank you so much for that really comprehensive presentation. This is so funny. I had forgotten how like beautifully soft-spoken you were. And I was
I
just like,
tried to be louder. Jules was like,
no.
you have to be
I
loud.
could hear, and it was coming up on the closed captioning, but I was like, oh, I just remember this voice, and it was just really nice to hear you again. So yeah, I'm really resonating with what I'm hearing because we're currently working the recommendations for clinical guidance working group with the community of practice is working on a document around take-home doses. And one of the main things that's coming out of that is the need for more flexibility and the need for an increased provision of it because it actually allows for more agency and control in people's lives. Yeah, so that was really resonating for me as you were saying that. And I think the other thing for me too is the focus on like providing folks with like a vast continuum of care, right? Like it's not like this and or thing, like it's not like a this or that thing. It's like a both and, like it can be this wide spectrum of services, like all the way from like, you know, folks who want to take a more like treatment or abstinence or recovery kind of journey approach, or like the addictions medicine approach, or like harm reduction, safety supply, like iOAT is in there, OAT is in there. Like I think that really making really breaking down that like sort of false dichotomy I think that we often see in like this type of work. It's actually, it's not that. It's like it's a continuum that people need to be provided with it, that have options. And I'm like really hearing that from the research and from some of those quotes, especially, I found particularly powerful. Um, so if anybody wants to pop questions in, I do see one question. Anybody is also welcome to put them in the Q&A. I also have a couple up the back of my sleeve just in case nobody's asking anything. The one thing we will do though right now is we'll launch a poll, and we'll also pop in a feedback survey link. So the poll just asks a couple of questions about like the region you're in, the position that you have, that kind of thing. There it is. Thank you, Fola. So you can answer that. And then in the, let's see if Fola and I can beat each other to it. There'll be a survey link that'll come through. We'll also share that survey feedback with Samara. And that's helpful for us to know, like both us and for the presenters, how today went, what we did good, what you want us to keep doing, and what you want us to start doing and stop doing. So I'll get you to fill that out. We'll just give it like I'll give you like a 30-second breath. Like if you need a drink of water, like take care of yourself. Any other questions, please just pop them into the Q&A or even the chat. It's crickets out there, so you can just pop your questions in the chat and keep that happening too. I think what I'll do is I'll pop you the first question, if you're ready. Yeah,
Yep.
we'll just leave the poll open. That's fine. It'll annoy people enough that they'll fill it out. Oh, you're
Sorry,
typing
I
the answer.
clicked
No, it's okay.
something.
It's
I thought
okay.
I had to
It
type
said
it.
what I'm going to do is I'll read it off, and then everybody, because nobody can
Uh,
see the
I'll
question.
stop touching
So
things.
no, it's fine. You're good. You're good. So I've done that a million times, and you can't reopen it. Did your participants have past experience in dilaudid or oral hydromorphine programs? I'm curious if they spoke about the difference in flexibility between iOAT versus oral safer supply programs.
So this was before a lot of people, well, not a lot, but like some people were getting prescribed oral dilaudid and or hydromorphone. So a lot of them didn't have past experiences being prescribed it under risk mitigation or safer supply guidelines. The only thing I think would be the dosing's pretty different for oral hydromorphone versus injectable opioid agonist treatment. Like usually with IO, much higher doses of hydromorphone.
Mm-hmm.
And so, but definitely around the flexibility would be something that it would have been interesting to explore, but just it wasn't around because this was I finished data collection I had to stop data collection in 2020. So, but I think it would be interesting in the future to focus on women's engagement with safer supply or oral hydromorphone programming and ways that they are using it to experience more agency, and I hope that some of the findings from this would be informative for that.
You're making me think of I'm sorry to name drop, like Rose Schmidt has some really great work, and that team has some really great work around like gendered experiences of safer supply. So I'll try to find a
Yeah.
couple of those links, because they're like it's like this research is in progress and it's like stuff that's coming out, but I'll try to find it because it was a really good paper. It had Nat, Rose, Carol, I think. I'll take a look. But yeah, that's a good
There's
question.
also
The other thing I wanted, sorry, yeah, go ahead.
oh no, I'll just put this person, I think her name's Ginger from at U of Ic, did some work on safer supply and gender in
Okay.
that. It looks really great.
Oh, cool. Okay, it's a YouTube. Oh, whoops, I better pause. Ooh, okay. Oh, that's from the BC. Oh, yeah, okay. It's a collab. Oh, nice. Okay. So we'll also include all of the links, by the way, for these resources and stuff in like the webinar page that we're gonna host. So don't worry if you like can't grab things. This might also be the thing I'm thinking of, but I'll search for the other ones after. The other question I had in that was about, yeah, like if you can just briefly remind me the timeline that you started the research when, and then you had to stop because of COVID in, like you said,
Mm-hmm.
2020. When did you start?
2018, like May
18. Okay.
2018. Yeah,
Okay. Okay. So yeah, and that would have also been, yeah, like you said before, like the risk mitigation came in and yeah, or like just as it was kind of coming in. Yeah, interesting.
yeah.
There's another question um, from a community practice member. What is one takeaway that you would like us to have? And they say, thank you very much.
Um, I think it would be around agency, like finding
Mm,
ways to like future programming focusing on fostering women's agency. And
mhm,
from the women that I spoke to and my conversations with staff at iOAT programs around providing support for those programs to be flexible. I think it takes a
mhm,
lot of resources and energy to provide. And I think that's often undervalued or not
mhm,
recognized, how the importance that that relational care or patient and sorry, the relational care plays in providing that essential patient-centered care. Um, it's so much work, and I think it also really helps um, for women to gain uh, or for women to have more agency in their treatment when they're able to have those connections with healthcare providers who truly understand their social context. But that always takes some, like anything, takes a lot of time to build that trust. And yeah, sorry, maybe that wasn't one takeaway, but
no. No, I think it's a really good, like
yeah,
it takes a lot, like, yeah, it takes a lot of time to build trust. And there's only so many prescribers and healthcare providers in this moment, right? That are available, willing, like to do this kind of work. So it's like up against so many different barriers of being able to provide access to care and like a strong
yeah.
continuum of care, you know?
And there was so much strain with COVID on a lot of these programs, and I know a lot of the programs, like some of the feedback I got was like, well, I can't even open an iOAT program, never mind a
Hmm.
women's only one.
Hmm.
And so there's just a lot of strain for programs generally. Um,
Hmm.
and the ones that I was working in were working under a lot of pressure and a lot of limited resources, and yet we're still able to build these strong connections with women. And so just emphasizing the importance of that and finding ways to support that so that women can have more agency and control over how their program's delivered and what outcomes they'd like to achieve.
I'm going to remind folks that they can pop any questions that they have in the Q&A. I kind of have a sense that this is going to wind at the latest 4 p.m. Eastern, 1 p.m. PT. Oh, there is a question in the chat. Have you seen any Indigenous specific, culturally relevant IOT locations in the DTES or the downtown east side? Thank you for the presentation! Exclamation mark.
I think there was one out of Kalalalam in the downtown east side,
Mhm.
but I don't know where it's at now. I can put the link to that. Um,
I got you. I got it.
oh, sorry.
Oh no, you're good. There's an,
But I don't know.
how do I want to say it? Here.
That was the only one at the time I did was more engaged in data collection.
Mhm. Um, that would be the main thing to check out. We also had, I'm just thinking we had let me just give me a sec to pull it up. We had a webinar with them. We hosted them is it a research webinar, I think? Let me just pull it up for you because it was really good. Here it is. Here. This is the webinar we had with the Kalala crew.
Oh, that's
That
nice.
was really interesting. Yeah, it was really, really interesting. I wouldn't say, sorry, I wouldn't say it's super specific to iOAT though, but it will give you kind of a nice overview of this like the space itself. Really cool.
And I
Uh,
don't know if they still do it or what
mhm, mhm.
happened to the program, sorry.
Yeah. Um, were you surprised by any findings?
Um, Maybe not surprised, but something that was, I think, like important for me to challenge, or like that I thought about a lot, was sometimes in literature on women's experiences or gendered focused stuff, it's a lot of can be really like trauma focused or about like violence, which, and I'm not to say that it's not important and that doesn't happen, but um, the specifically the finding on how women were enrolled with their partners and how that was really supportive. I think sometimes a lot of the research is framed really in a way that's always like um, yeah, focused, or maybe not just research, but just focused in a way that's not considering areas of strength, I guess, or strength based. And so I thought that was something I tried and that women were really adamant about around that, I want to be on this program with my partner. We have this really supportive relationship. And so that's why I tried to emphasize in the findings this need for diverse focus and that, and yeah.
If anybody has any final questions, please pop them in the Q&A box or even the chat. I have a question for you, and this goes back to I have a BA in anthropology from like many years ago. And I remember being really interested in the concept of ethnography. And when you were talking about taking ethnographic observations or notes, I was wondering if you could just speak a bit more about it. Like tell me just like in, what's this like how do you do it? How did you do it? What did that look like?
The observations.
Mhm.
Um, yeah, so that one after I interviewed people, I invited them to spend time with me out because sometimes when you do qualitative interviews with people, it can be really formal
Mhm.
and not very natural. And a big part of the study was to understand people's social context, and that's hard to understand in like a interview room where you're kind of everyone feels a little bit uncomfortable. So people were invited to spend time with me, and usually I just asked them to take me to places that they thought were important to them in the neighborhood, and we would have a chat and coffee and and we talk about IOUT, sure, but also things that were going on in their lives that impacted their experience with the treatment. And then afterwards, you have to go and you basically write up um, everything that you spoke about or saw or felt. And there's space for, because I'm focused on critical ethnography, I was really interested in like things around power. And that one's also focused a lot about your own reflexivity. So, like, where am I coming from as well? And like, what am I seeing based on my own like positionality, they call it, like my background and how I felt about things. Um, so, yeah. So some of the field notes were around like in the paper, if you read the paper, were around like um, sometimes women, like if I went to the space with the women, I'd see them arguing or with the staff about time limits and were really upset and would leave like really upset. And so that's kind of reflected in some of the results that I put in the paper. Yeah.
Yeah, so it's not you like sitting there like with your little tape recorder. on like the side of
Oh
the
no,
street with like your notebook, like like watching people, like that's sort of like the
that
vision I
would be
think I had
so
on my
weird.
phone. It would be so weird, right? Yeah, okay, that's what I was, I was like thinking.
No,
Okay.
usually I just like go for coffee or like and
Yeah.
we'll walk around. And I also don't, if people don't want me to record something, I
Mm-hmm.
won't. And everything's I don't put people's names and I really try and keep it anonymous as well.
Mm-hmm.
And it's more like there's you can't like just observe things like
Mm-hmm.
that. Like I worked in the area for a while, so I'll run into people
Yeah.
I know and like it's a little bit more engaged. And
Mm-hmm.
that fits within that critical ethnographic approach that I was talking about. Yeah.
Cool. Well, I think that the research you've done is really fantastic and interesting and adds, I think, to some of the gaps that are sort of in research around iOAT right now. And I'm really hopeful to see more of this, and especially around like gendered perspectives of safer supply and transitions into safer supply, right? Um, yeah. Unless there's any other questions, like I think I'll just say thank you. And yeah, stay tuned in our newsletter and on our social media and on our website if you check it regularly under the past events. This will be considered a past research spotlight webinar event. You can just click there, and there'll be a permanent web page that has all the resources that we mentioned, the slides that were presented, the research paper itself, etc. Um, yeah, I'm gonna leave like a reflexive silence of I can commit to 10 seconds. That's it. And then my awkwardness has to call it. I'm going to sit here for 10 seconds in silence. Okay, I wasn't counting, but I'm realizing how hard it is for me to sit in silence. We'll stop the recording there. Thank you, Fola.